So my name is Jeff Rolfe. I'm a neuromuscular neurologist, and I'm happy to have two folks with me from UCSF. Ann Urado, our neuromuscular nurse, and then Dr. Paula Sampaniero, a clinical fellow who's going to join our faculty next year. So our plan for this morning are to have three talks. I'm going to give a few introductory remarks about peripheral neuropathy, and then Paul's going to go through some cases and sort of highlight sort of the experience of a patient being worked up for neuropathy, and then I'll speak after that and relay some new stuff that was presented at the American Academy of Neurology meeting, which is actually currently still going on. It goes on for the whole week. So I think up on this slide is again the structure of our talk, and we'll get started. So as you know, neuropathy means a disease of nerve. And first of all, neuropathy is a very common problem, as you know. I know there's a statement on the WNAC website how it's the most common disease you've never heard of, and that's really true. And the overall prevalence is a little hard for me to read from the back, but I think it should say about 2.4% of the population. And if you work that out in the United States, that works out to about like 20 million people, 15 to 20 million people. So it's a very large number. And it's much bigger than the burden of Alzheimer's disease, which is more like 2.5 to 5 million, or Parkinson's disease, which is around 1 million. And everybody's heard of those diseases, but not so much neuropathy. And again, I know the print is a little bit small, but basically it's a common disease you haven't heard of. And I guess the important thing is that this is a painful condition for many of you. And I know for some of you, the problem is balance and weakness, but probably most of the people in the audience, pain is the main reason why you're coming here today. Who here in the audience has neuropathic pain? So quite a few hands. I'm surprised there are actually not more hands. It's often a major motivating factor for people to join support groups. So just to make sure we're all on the same page, some of these slides are very basic, but we're talking about peripheral neuropathy, and what the peripheral means is the peripheral nervous system, which is in the box there. It's not the brain and spinal cord, that's the central nervous system. We're talking about the nerves in the trunk of the body, and the nerves in the limbs, and also the nerves that go to the organs, the autonomic nervous system. In a way, the English language is inadequate to describe the nerve. I mean, it's almost like, remember the Smurfs? They use the term Smurf as a verb and a noun. Well, we use the same word nerve to mean the nerve trunk or an individual nerve fiber. So this slide just shows how you have individual microscopic nerve fibers that we also call nerves, and the fatter ones are surrounded by a fatty sheath called myelin, which increases the conduction property of the nerve. Okay, and motor nerves go to muscle and are responsible for movement, and nerves, of course, the skin carry information the other way towards the body. And I think the animation got screwed up there a little bit, but there's supposed to be a little green leaf that touches the skin. There's a little electric impulse that goes towards the spinal cord. So your motor information goes outward, the sensory information goes inward to the body. The nerves that go to the muscle are all large fibers, meaning that they have a large diameter, whereas the sensory fibers are more highly variable in terms of their diameters. So a large fiber is a fiber with a large diameter, and those sensory fibers mediate things like vibration sensation and discriminatory light touch. And then the small fibers are the pain and temperature fibers. And this relates to at least one of the cases that we'll discuss about later on. Many of you have a process in which the distal part of the nerve is diseased. So it's so-called dying back axonopathy, and that's what I've depicted in this slide, is sort of those little dotty parts of the nerve. So if the nerve dies back, then when you want to move, the impulse can't get to the muscle, and then if something touches you, the information can't get to the nerve. Now, a mystery to many patients is the paradox of peripheral neuropathy, how you can be numb, have numbness and pain and numbness in the same location. The numbness makes sense because there's just not enough nerve fibers, so the pain is a more difficult thing to explain. And the main reason that there's pain is that the nerve fibers that are still there have changes in the expression of molecules on their surface that lead them to fire more readily, and sometimes without any input whatsoever. And that is the basis of most neuropathic pain. And many of you experience the wide range of neuropathic pain types. It can be anything from itching is the main symptom, to burning, stabbing, a swollen feeling. A very common sensation is that there's like something on the sole of the foot, like a pad. There's something changed about the tissue seems swollen or too thin. Let me just put all these things together. So a neurologist, when we think about neuropathy, one of the first breakdowns in how we think about it is whether it is a focal or a multifocal neuropathy, or sort of just a single nerve, or is it a patchy process, or is it symmetric and generalized? So a common example of a focal neuropathy would be carpal tunnel syndrome, which, by the way, can coexist with a sort of a standard neuropathy, for example, in somebody with diabetes or amyloidosis. Many of the people here, I imagine, have generalized neuropathies, and then we further subdivide those into axonal or demyelinating types. The reason this is important is because there are specific treatments, particularly for the demyelinating neuropathies. There are specific treatments for those. So we kind of need to pair up the patient with the treatment. So it's important to figure that out. The symptoms of polyneuropathy, well, many of you live with this every day. It starts off usually with numbness or tingling or pain in the feet, and then over time the symptoms work their way up. This is over months to years, from the foot to the mid-shin area, then to the knee. And then when the symptoms get to the knees, that's usually or often when the hands can get affected. And this sort of cartoon sort of illustrates that with the involvement first in the feet and then in the shin area. And then again, when it gets to the knees, then the hands are often affected. Sometimes the hands can be affected early on. And if the hands are affected early on, that does sort of shift the neurologist's thinking about what could be going on. The causes of polyneuropathy, Paul, in setting up this talk, he says, wait, you're forgetting some things. And I told him that I kept it into 5 categories because that's the number of fingers I have in my hand. And when I discuss with patients, I like to just touch my fingers. So the one finger is, in terms of cause, is the neuropathy can be connected to some medical problem. So there's a medical illness that's driving the neuropathy. And in a way, I think we're always trying to find that, because the best way to fix a neuropathy is to find an identifiable cause, and then we could, if we address that cause, then we could fix the problem. But there are a variety of medical disorders associated with neuropathy. Again, I know the print is very small there, but advanced kidney disease, liver disease, I mentioned this thing called amyloidosis, where you have a deposition of protein in tissues. There's a long laundry list of medical problems. Another category are toxins and medications, and the patients that we see, this is mainly connected or caused by pharmaceutical drugs the patient takes, and many pharmaceutical drugs is, one of their negative effects is neuropathy, and sometimes it's very predictable, but the drug is so necessary that we sort of live with the neuropathy risk. So there are a number of toxins. Alcohol is another major toxin to the nerve. And then the other category is vitamin deficiencies. Usually this is mainly B12 deficiency, but I have a case that I'll present later on that illustrates how other vitamin deficiencies can play into it. And then I think I'm on figure number 4 now, hereditary. So there can, there's genetic factors are at play, very common, quite commonly in neuropathy. Maybe about 20% or 30% of our cases have a genetic component. And then the last category is the feared idiopathic or cryptogenic. in our practice at UCSF, this is a very high percentage because many of our patients come from other neurologists and they've already been worked up. So we sort of have in our clinic the ones that are trickier to figure out, and I would say about 40 to 50% of our patients who come in with burning or tingling in their feet, about that percentage have a neuropathy of unclear cause. And anyway, that's idiopathic, is the number 5. So I think that is it for my introduction, or the introduction part of this talk, and now I'm going to hand it over to Dr. Sampanero for the next part.
Dr. Ralph and I thought it would be helpful maybe to take some of this broader information and apply it to a few cases, both to illustrate some of the ways that we as neurologists approach neuropathy. Thank you. And also just to apply some of this so that it maybe is a little bit more relevant to you as patients and individuals. I think the other thing that's nice when we talk about cases is we can talk about some primary therapies, some of which you may or may not take. But the categories are growing, and we have more and more treatments than ever before. So the last thing I would like to do is provide a little bit of optimism about sort of the rapidly expanding treatments that we now have at our disposal, and that's changed a lot even in the last 5 years. So case number 1. So this is a 72-year-old mechanical engineer. He has a past medical history, which we see often, similar things, hypertension, type 2 diabetes, history of coronary artery disease. He had a surgery for a bypass graft in 2010. And he came to see us 4 or 5 years ago now with burning, tingling, and numbness in his toes. He had no weakness and no balance problem, but his primary symptoms was this pain. And I know many of you have probably relate to this gentleman. So as a neurologist, we tend to follow a stereotyped kind of evaluation, and then as we go through talking with the patient, we start to fine-tune and individualize the care based on what we hear. So we always take a history and we ask, for example, is there a family history of similar symptoms? We look for things like toxic exposures, which include alcohol use, for example. We think about patients' past medical histories, what other things they may have been exposed to in life. And then invariably we do a good neurologic exam, which includes both an examination of the feet in the area that's in pain or the area that's weak, and then a detailed neurologic exam. And, we often, after we see a patient, we'll send them to the lab to get blood work done, looking for common causes of neuropathy. So we'll check things like diabetes. If in their exposure history we hear about potential risks for things like hepatitis C, we'll check for that. And then just to get a little bit more clarity on the neuropathy and what's involved, oftentimes we'll refer patients for an electrical study, which I'm sure many of you have had. This is called an EMG and a nerve conduction study. Rarely, if the case is particularly confusing, we also sometimes will refer a patient for a skin or a nerve biopsy. But I would say that's probably done in a small minority of cases. So this is just going back to Dr. Ralph's slide, talking about the differential that we think about, and we sort of go through this in our mind based on what patients tell us. And in this particular case, this patient had an EMG and nerve conduction study that showed a mild length-dependent polyneuropathy that was mostly in the feet, really not involving his hands. And then when we were reviewing his lab results, we saw that this patient's hemoglobin A1C, which is the test that we follow for his diabetes control, had gone up in the last 3 years. So it went from a 7.3 to a 9. So this was in the absence of anything else, this is a really good story for a diabetic polyneuropathy. And as Dr. Ralph mentioned, it's the most common polyneuropathy that we see. So that I would say if there's a good history of this and a history of diabetes, worsening control, and the right symptoms, this is most of the time what it's going to end up being. It's diabetic polyneuropathy. The mechanism of diabetic polyneuropathy in part has to do with the actual sugar, increased sugar in the blood, causing these glycosylation products which end up accumulating in different parts of the body. And then the sugar itself is not good for the small vessels that supply oxygen to the nerves. And so microvascular injuries can happen and damage the nerves directly. So when we think about polyneuropathies in general, I would like to argue there's two kinds of treatments that we think about. We think about first the primary therapy, what can we do to actually stop the disease process itself? And that varies depending on what kind of polyneuropathy you have. So in the case of diabetes, we think about treating the diabetes itself, so treating the systemic illness. In the case of a nutritional deficiency, for example, we would treat and replete somebody of their vitamin B12. And then the secondary kind of treatment we think about are how do we manage a patient's symptoms. Oftentimes it's the pain that's unbearable. Patients don't notice that their hemoglobin A1C and their diabetes control may have worsened over the last few years, but they certainly remember and appreciate the pain. And so that's equally as important a job that we do. And so in this case, for the diabetes, we're going to focus on treating the underlying condition, which is the diabetes, and we're going to focus on treating this patient's pain. So there's evidence to suggest that actually tighter glycemic control in diabetes can actually help the polyneuropathy. And I'm sorry that you probably can't read this, but these are just pointing out a few studies that were done in the past that suggested that when patients' glucose control is better, their neuropathy sometimes improves or at least plateaus and doesn't get any worse, or if it does get worse, it gets worse much more slowly. And so that's the first part that we do. And then I think in the case of diabetes, oftentimes a lot of the focus in our discussion, in addition to glucose control, is often how do we treat this pain. And so I would like to take this case and focus a little bit on our approach to neuropathic pain and how we manage it. I think sometimes that can be a little bit mysterious to patients why we pick one drug over the other. So my hope is after this, you'll have more of an understanding of what our thought process is and how we approach neuropathic pain. So I would say the first thing that we do, I'll go back to this slide, is the American Academy of Neurology has a list of medications that they recommend, and anecdotally, we have medications that we see patients respond to. And so we often will pick a medication based on a patient as an individual, what sort of past medical history they have, what sort of side effects we're maybe trying to avoid. And so we'll usually pick one drug, and we'll start it at a low dose, and we'll work our way up as needed. And so you'll see here, scenario number one is, let's say, for example, we start a patient on gabapentin, which I'll talk about more in a minute, and they have a partial pain relief at the low dose that we started. Well, in that case, we'll just increase the dose and keep them on one medicine for their pain until we get adequate pain relief. And the goal here is to get adequate pain relief while also minimizing any potential side effects that a particular drug might have on someone. Well, scenario number two often happens as well, where we'll have somebody on gabapentin and we'll max out the dose. And so in that case, if the pain is not completely controlled, then we'll often consider adding a second therapy. And the strategy in adding a second therapy is to pick another drug that has a different mechanism of action, the idea that you're targeting two different areas of the nerve to try and improve the pain, while also minimizing the number of drug-drug interactions. And then scenario number three, which certainly does happen, is we'll start a patient on a medicine like gabapentin, and they have no response whatsoever. It just does not help their pain at all. Well, there's no reason for us to keep a patient on that medicine, and so we'll take them off that medicine and try an alternative therapy to see if that might work. There's obviously many pitfalls to treating neuropathic pain, and there's some challenges involved. Finding the right dose and the right medication is an individualized effort between a neurologist and the patient. Oftentimes patients will experience side effects, and so we have to balance that. Some of the neuropathic pain medicines, like gabapentin, for example, you have to take quite frequently. A lot of patients find it very inconvenient to have to worry about taking a medicine 3 times a day, for example. So we think about that too. And then, as Dr. Ralph was mentioning, the prevalence of neuropathy increases as we age. And so often our patient population tends to be middle-aged or our senior population, and those folks tend to get more side effects with drugs, and they tend to be on more than just the neuropathic pain medicines that we're prescribing, and so the risk of so-called polypharmacy increases in this population in particular. So we're always trying to be mindful of that. So let's take the first medication that I'm sure many of you have experience with. It's sort of our tried and true drug. It's gabapentin. Gabapentin has an interesting mechanism of action. It binds to voltage-dependent calcium channels. And the goal of it is really to sort of turn the volume down on the pain response. It's a good medication. We often prescribe it. It's first line. It's generic, and so it doesn't cost much for patients to start it. Many of our patients do quite well on gabapentin. I think the biggest downfalls of gabapentin are the frequency of the dosing, 3 times a day, and there's also a fair number of side effects from gabapentin, including some patients experience cognitive dizziness or clouding. Some folks experience weight gain. And most of the time, the reason we stop gabapentin or switch gabapentin is because at a high enough dose, patients are feeling these side effects and they don't like that, and they'll take the pain rather than the cognitive fuzziness that they feel. I guess it's not a new kid on the block anymore, but pregabalin or Lyrica came out certainly more recently than gabapentin, and it's actually going generic in the summertime. And it's a similar drug with a similar mechanism of action, but it's more potent than gabapentin. And I've anecdotally had patients who feel that it doesn't have quite the same cognitive side effects that gabapentin does. So oftentimes, I know I personally, if a patient isn't doing well on gabapentin, I'll try to switch them over to Lyrica and see if that improves things. And hopefully that becomes easier to do as this medication goes generic in July. Another class of medications that may be considered are the quote-unquote anticonvulsants. These drugs, and I'm sorry that the slides are small, or the words are small, these drugs actually started out as anti-seizure medications, but the properties that help prevent the overexcitation in the brain that happens with seizures are the same properties that can help the overexcitation of nerves that happen in neuropathic pain. So occasionally, although it's not often the first drug that we will choose, we will pick one of these anticonvulsant drugs as a second-line therapy. And these include things like carbamazepine, oxcarbazepine. Rarely, but occasionally we'll put people on medications like Topamax, for example. Sometimes this works out because if a patient has a migraine headaches in addition to neuropathy, sometimes Topamax can treat both with just one drug. Another category of medicines that I personally like are they fall under the category of antidepressants, but we find that they're very, very helpful for patients with neuropathic pain. So the tricyclic medications, which include things like nortriptyline, also known as Pamelor, or amitriptyline, also known as Elavil, are medications that work on norepinephrine and to some degree a little bit of serotonin, and can modulate the pain response through multiple mechanisms. The big side effect with the tricyclics, however, is that some patients feel that it makes them a little bit sleepy. Other patients feel that it gives them a dry mouth and they don't like that. Some people experience weight gain on the tricyclics, and so you can see there's a recurring theme. A lot of times what we try to do is balance the side effects with the effect of the drug. Also under the category of the antidepressants are the serotonin norepinephrine reuptake inhibitors, and these include things like duloxetine or Cymbalta, which I'm sure many of you have tried, also Effexor. And these medications, duloxetine in particular, are first line and FDA approved for the treatment of diabetic neuropathy. You may have noticed that we don't prescribe things like Prozac for neuropathy, and that's because the drugs that specifically just act on serotonin don't seem to really help people with neuropathy or neuropathic pain. It may help them if they're depressed about their neuropathy, but it won't help them for the pain specifically. Tramadol is an interesting one. I'm not sure, I don't know if you, Dr. Rupp, prescribe this more than I do. I don't tend to prescribe this that often. It's a medicine that is similar in that it blocks norepinephrine and serotonin reuptake, but it also has a weak binding on the mu opioid receptors. So it's sort of, in some ways, like oxycodone light. It can partially modulate these responses, and there's been several studies to show that this medication is effective in neuropathy. I think opioids, for a lot of patients, particularly patients who are in severe pain, is one of the elephants in the room when you come to see a neurologist. And I think part of that is because opiates are effective. The issue is that they have a high addictive property, and there's been a lot of press, as you know, of patients abusing opiates and lots of deaths related to opiate overdoses. The medications themselves are really best used for short-term purposes. So for example, an orthopedist, if a patient has a broken arm, may prescribe a short course of oxycodone, but they're not great medicines because of their addictive properties chronically. And oftentimes when we're dealing with neuropathic pain, these tend to be more chronic pains that we're dealing with. So you may notice that neurologists in general, with some exception, will try to avoid these medications in patients. And that's only because we have many other therapies that don't quite have the addictive properties and, quite frankly, don't have the stigma around opioids. I think an underappreciated category of neuropathic pain medications are the topical ones. So lidocaine patches for some patients can be very effective, and their big benefit is that they don't have a lot of systemic uptake. So you can put lidocaine over the feet and get that pain relief that you're looking for without feeling doped up on an opiate, for example. Capsaicin too is a popular one, and it has an interesting mechanism. So capsaicin is from the chili pepper, and the idea is you actually put something that causes the feet to burn even more, so that you kind of deaden the nerves. The brain just says, something's going on here, I don't understand it, and we're just going to sort of turn off the pain response. Capsaicin for many people can be effective. The only big side effect I hear about is people will rub the capsaicin on their feet and then accidentally scratch their nose or rub their eye, and then you have another problem going on. But capsaicin can be quite effective.
It just acts on.
Lidocaine in the form of icy hot is also effective, and there's also hemorrhoid creams that some patients have used because they're cheaper, like Recticare, that can also be effective on the feet, believe it or not. Nutritional supplements are an interesting topic, and I have a suspicion that some of you may be taking things like alpha lipoic acid or L-carnitine, and oftentimes in clinic, I probably spend 5 to 10 minutes discussing things like, are these supplements helpful? And I think the short answer is that there's a bit of a mixed bag. There's been some evidence that maybe things like alpha lipoic are helpful in that patients feel like they have less pain when they take it. But the data on nutritional supplements has been a little bit mixed. I know we have a Q&A session coming up. If you have a specific question, I think Dr. Ralph probably would be able to answer some of these a bit better than me. But this is something that patients do take, and I personally don't mind that they take it if they feel like it's helping. This slide may be a little bit dated, but as you know, in the state of California, not only can you get medical cannabis, you can get regular cannabis, and some patients feel that CBD oil or marijuana, even in this form that has THC in it, can be helpful in improving neuropathic pain. Be happy to answer other questions like that in the Q&A session as well. Another common thing that patients will ask us about are TENS devices or electrical stimulation. And it comes in many forms, and the general idea is It's actually similar to the capsaicin, I think, where you provide an electrical stimulus to the nerves. And there's something about adding that stimulus can help with the neuropathic pain. I don't know if there's a ton of evidence behind its efficacy, but for patients who do feel like it helps them, I don't see really any side effects from it. So I often tell my patients that they can keep using it if they'd like. And then there's some other things which also I think the jury's out on, but patients anecdotally have argued that it's helpful. Things like acupuncture. Some people put magnetic insoles in their feet, something about the magnetic field being able to help the neuropathy. And so there's a lot of other things out there that people have tried in addition to the pharmacologic therapies that they anecdotally feel are beneficial. Case 2. So if that was about sort of neuropathy from a systemic condition and a discussion of neuropathic pain, case 2 is about a 50-year-old attorney who has a slightly more rare condition. So she came to the clinic reporting 5 months of difficulty climbing stairs and then 3 months of frank gait imbalance just when standing up, and she had numbness and tingling in her toes. And then a month prior to seeing us, she felt that she had difficulty buttoning her clothes and her fine motor in her fingers was impaired. So again, as a neurologist, we have a sort of stereotype rubric that we follow, and then we again fine-tune things based on the history. So again, we re-elicited this history from this nice lady, and then we did our neurologic exam. And interestingly, on neurologic exam, unlike the first patient who had mostly sensory problems, there was a lot more weakness that we appreciated distally in her legs. And we also noticed that her reflexes, which, as you probably noticed, neurology, we love reflexes. Her reflexes were noticeably absent everywhere, even in her arms above her hands, where her strength was otherwise quite good. And then she also had impaired sensory function in her toes, and she couldn't feel the vibration of the tuning fork in her toes, in her ankles, or even her knees. We again recommended a battery of lab tests, which we sent her for, and then we again, to further characterize her neuropathy, sent her for an EMG. Interestingly, her EMG, like the first case, showed a neuropathy, which was a bit worse and had progressed more than the first case, but it also showed this pattern of slowing of the nerve conductions and areas of conduction block where it seemed like the nerve signal just couldn't get through. And that pattern where the nerves firing but are firing much more slowly, and there's areas of block, that is a pattern that is concerning for demyelination. So Dr. Ralph mentioned that you have the nerve, and the nerve is like a wire, and you have the copper in the wire that sends the signal, and then you have the rubber around the wire, which provides the insulation for the conduction to travel down. And myelin is a protein that provides insulation for the nerve, and it looked like she had a problem with the insulation of her nerves, which is why the signal was getting sent more slowly. So based on that, we were suspicious for a relatively uncommon condition, and so we actually did a spinal tap or a lumbar puncture. And we noted that although she didn't have any infection in her spinal fluid, she had a high protein level in her spinal fluid. And that pattern of slowed nerves and an elevated protein in the spinal fluid is a classic example of a condition known as chronic inflammatory demyelinating polyneuropathy, or CIDP, which is a much easier thing to say. This condition, unlike the other condition, is an autoimmune attack on the nerves. And some of you may have heard about Guillain-Barré syndrome. This is sort of the more slow, bumbling cousin of Guillain-Barré syndrome. And it has a similar pattern that just happens much more slowly over months rather than days to weeks. The reason I wanted to show you this example of CIDP is this is another example of how we think about why understanding what's causing the nerve injury can be helpful. So in this case, because she has an immune-mediated attack on the nerves, rather than treat her blood sugar, we're focusing on treating her immune system and quieting down her immune system. And then because she wasn't having a whole lot of pain, she was having mostly weakness, our focus was not on neuropathic pain medicine, but rather providing her with assistive devices to aid in her mobility. So in CIDP, which is an immune attack on the nerves, we have several immunotherapies, and this is a slide I took from Dr. Ralph. I agree, we sort of think of it in a triad where all three of these medicines, which I'll go into, can be effective. So some of you, for other conditions, or if you have CIDP, may have received intravenous immunoglobulin, also known as IVIG. The way IVIG works is actually a little bit unclear. We think that flooding the body with this immunoglobulin does something to modulate the immune response and quiet it down. The pros are that it's very, very effective. The cons are that it's an infusion, and there can be infusion-related reactions, and it can often lead to people feeling almost flu-like with fever, rarely, but chills and muscle aches. Sometimes people can also have an allergy to IVIG. But when it works, it's very, very effective. Another thing that we use, which some of you may have also been on in the past, are steroids. So in these conditions, we can also use things such as prednisone to treat the nerves. And the effect can be rather quick, over a few months. And the pros are that it's much easier to take a pill than it is to go to an infusion center and receive an infusion. But the cons are that there's all sorts of side effects of steroids, some of which you may know about, including things like worsening your diabetes, worsening your blood pressure. People who take steroids chronically can have changes in the way fat is deposited in their body. So this woman you see right there who's been on steroids chronically has a lot of increased fat in her face, and that can be a chronic sign of it. But the medications are effective, and often patients will take this if it means that they can walk. And then the last therapy is something called plasma exchange. This is a pretty involved therapy, but it's very, very effective. It involves a patient often coming into the hospital, getting a catheter placed, and exchanging her plasma or his plasma for a filtered plasma that doesn't have the immune proteins that are causing the attack on the nerves. And the benefits are that it's very, very effective. The downsides are that it's much more invasive than the others. And then obviously this patient, this lawyer who came in, was having difficulty walking. And so in addition to thinking about how to treat the nerves themselves, we also wanted to focus on improving this woman's function. And we have lots of things that we have lots of things at our disposal. So we often will have a physical therapist or an occupational therapist see these patients alongside us, and they can help us fit patients with canes, orthotics and braces to help the weakness that they have in their ankles and in their feet, for example. These are a couple of braces known as AFOs, or ankle foot orthoses. And then we'll often prescribe some sort of course of physiotherapy, things like Tai Chi, or PT sessions with specific focus to gait and balance training can be very, very helpful, and they are a critical part of our treatment of patients like this. And lastly, case 3. So if the first case was diabetes, which is very common, and the second case was CIDP, which is less common, the third case is also in the less common category, but I think it's illustrative of where we're going with medicine and with neurology in general. So this is a case that Dr. Ralph and I recently saw, a 55-year-old man who was a construction worker who had a history of glaucoma, and he had a pacemaker placed a few years prior. And he came in with a much more chronic history. So rather than days or months, he had 3 years of worsening gait that was associated with pain, numbness, and weakness in his feet. He had sort of thought that maybe on the job, after he'd been on his feet all day, that he had just this pain and numbness and it was work-related, but eventually he sort of realized that it was much far out of proportion to what he should be expecting after a long day's work. So again, we took a history, and interestingly, in this history, he had a couple of things which were quite notable. So he did have a fair bit of alcohol consumption, but more interestingly, he had a father with similar symptoms. And his father, he told us that his father had a neuropathy in the past, and they didn't know what had caused it, and he was ultimately wheelchair bound, and his father ended up dying of a heart attack. But he always remembers his dad being in a wheelchair in the 60s and nobody really being able to figure that out. So again, we did a neurologic exam, and it essentially showed that he had involvement of weakness in his feet, he had weakness in his legs, he had some mild weakness in his hands. Unlike the patient in case 2, however, he had a fair bit of pain, which was interesting to us. And so we again did this, what we do as a matter of routine, where we send for lab tests. We also referred him for an EMG. And the EMG this time also showed and proved that he did have, in fact, a neuropathy. Unfortunately for him, he did not have evidence of demyelination, which is something that, as neurologists, when we see that, we almost get excited because it's something that we can treat with one of these immune therapies and patients do quite well. He did not have any evidence of that. And his lab tests were fairly unremarkable. 20 years ago, or maybe 30 years ago, we may have sort of put this patient in the category of hereditary neuropathy with an unclear cause. Maybe we would call it an idiopathic neuropathy. We wouldn't be sure. We would just follow him and try to help him the best we could. Nowadays, however, we have far easier access to genetic testing. And in his particular case, we sent out this panel, which has up to 72 genes now, and there's more and more genes every year. And we got a hit, and the hit was on in the TTR gene. So this patient had a condition known as hereditary transthyretin amyloidosis. What you need to know essentially is that it's a protein that's made by the liver that folds abnormally and accumulates in different tissues in the body. And that history that he had, where he had a history of glaucoma, and also a history of a pacemaker at a fairly early age, were actually a canary in the coal mine, that there was maybe something else going on. And what we found out was he actually had a neuropathy from this abnormal protein that was accumulating in and around his nerves. I would say as early as 3 or 4 years ago, when the patient had this, there were a few medicines that we could put patients on to try and stabilize this protein from misfolding, but they didn't work tremendously well. They had some effects, but it was mild. But last year, there were 2 new genetic therapies that came out for this. So therapies that actually treat the genetic cause itself. So this is very exciting. These papers in the New England Journal came out in the same month. One was for patisiran and the other was for ionotersen. And the medication actually works to, it affects the transcript which in the cell which produces this protein and gets it to stop producing this abnormal protein. And this is not the only genetic therapy we have. On the screen, you'll see we now have genetic therapies for a pediatric condition called spinal muscular atrophy. They're also working on genetic therapies for another pediatric muscle condition called Duchenne's muscular dystrophy. And this hereditary transthyretin amyloidosis is just part of this opening salvo of genetic therapies that we now have at our disposal. And the therapies do exactly what they're supposed to. So in this particular case, this abnormal protein, in the black, you see this is what a patient not on the drugs level looked like and was sort of coasting at the same high level. And then they start the therapy, and in weeks, that abnormal protein, which is building up in their blood, just hits rock bottom. And patients actually report that they are improving, not just stabilizing, or improving with the medications. So this is really, really exciting stuff. As a newly minted neurologist, I'm very excited to be part of sort of the opening of these genetic therapies, and we're only discovering more and more every year. So in summary, with these cases, I hoped that I made a fair argument that we as neurologists like to individualize our assessment based on what a patient comes in with, both their symptoms and their past medical history. And then the treatment is also based on what the underlying cause is and what a patient's chief symptoms are. And our focus is typically, we try to be as focused as possible, not only on the primary condition, how to treat the underlying condition itself, but also on the secondary therapies, which include the symptoms. And we're always working to do better at that.
This week is the big neurology meeting called the American Academy of Neurology meeting.
But not all. No.
And this year it was in Philadelphia, and it's this whole week. It's a huge meeting. The events occupy the convention center in Philadelphia. And sort of picking out some highlights to share with you, I searched the abstract database and just used the keyword neuropathy, and 193 abstracts came back, so there's a lot. And I wanted to go over a few highlights that I thought would be of interest to you. And then, there are two pictures here of the building. So Philadelphia has a really spectacular city hall. It sort of looks a little bit like Independence Hall, but more dramatic, and that's there in the background. And then this is the convention center. Okay, so the first one I thought was interesting because some of you in the audience have had cancer, I would imagine. And there's a big new sort of technology for treating cancer, and that is various treatments can spur the immune system to attack the cancer. The problem is if you boost the immune system too much, then you get autoimmune diseases. So basically the immune system attacks tissues. And unfortunately, there have been a number of complications in which the immune system attacks the muscle, the nerve-muscle junction, and even the nerve. So there was this case of basically Guillain-Barré syndrome, which is sort of a more aggressive form of what Paul talked about. And it was induced by this drug called pembrolizumab. Everybody calls it Pembro. And this is a so-called checkpoint inhibitor, and there are a number of drugs in this category. But this person with metastatic urothelial cancer was on this therapy, developed severe weakness, and the patient was treated with things like steroids and some of the things that were already discussed. But this patient didn't do well, eventually died. So I just bring this up because this is a therapy that's really emerging, and it's a fantastic therapy. It usually goes smoothly, but there are some definite risks with this type of therapy, and we've seen them in our practice. Matter of fact, there were about 10 abstracts about the complications of these drugs at the meeting, so it's sort of a hot topic. So here's the rest of the slide about that. So again, the so-called immune checkpoint inhibitors are increasingly being used, and we are realizing that there are a lot of unforeseen side effects of these therapies. I should also say that today's talks and also the slides will be posted, I think, on the website, and you'll be able to read the print much better, probably on your computer screen. The next case I thought was interesting. So this is a family, the investigators described a family with a mutation in a gene called SCN11. So this gene encodes what's called the sodium channel, which is a molecule on the surface of the nerve that allows sodium ions to go in and out. And in order for your nerves to send signals, there has to be the flow of ions in and out. I mean, that's the fundamental basis of the electrical properties of your nerves. And people who have a mutation in the coding of this stretch of DNA can have a number of problems, including small fiber neuropathy and episodic pain syndromes, and also a congenital inability to feel pain, which is a very serious problem because, you know, none of us like pain, but pain is essential to protect our bodies, of course. So the investigators studied this family, and every person in the family that had this mutation had these episodes of pain, and some of them had neuropathy, some of them had symptoms of neuropathy, But interestingly, their nerve conduction studies were normal, and they even took it to the point of analyzing the skin, the density of nerves in the skin. And we do this for the so-called small fiber neuropathies. So those are the neuropathies in which the pain and temperature fibers are only affected. And it's a very sensitive test that we do at UCSF. And anyway, this test came back normal in these family members. And so I think this is interesting, because we sort of rely on our tests to make the diagnosis, right? So it's a little unsettling for everybody that these people had totally negative testing but had a definite neurological syndrome. So it is possible that all the standard testing we do, including the nerve studies and even the skin biopsies, to be negative. And this sort of makes sense when you understand that really our testing, what it looks for is a loss of nerve fibers or a loss of conduction. But suppose you have a problem which the only problem with the nerves is they're firing more than they should be. So there's a normal number or density of nerves, but they just fire when they shouldn't be. And our testing is not very good at that. Hopefully in the future we'll develop fancier tests that actually analyze these molecules on the surface of nerve. These things called sodium channels, and we'll be able to nail down the diagnosis in those folks. So, so this just reiterates here on the slide that our testing really mainly depends on a loss of nerve, but you may have a condition in which there is no loss of nerve. That still would be a neuropathy. So I just have a little picture with Mr. Franklin here. It was raining, so he stopped flying his kite to take his picture. And then there was an art gallery right across the street from the convention center. And one of my favorite paintings was there. It's a medical painting. And it's this painting called Dr. Gross's Clinic. And it's a little hard for you to see. Again, you'll see it when it's posted, but he has a scalpel in his hand, and he's wearing his street clothes, and he's taking out a tumor in a leg, just wearing his clothes, and there's no, well, there may be some like ether or something, because there's a person administering something over the face, but really no sterile technique here at all. The painter Eakes did another painting about 10 years later when antiseptic techniques they're still very primitive, but at least it was brighter in the room, and at that time professional nursing had started. There was a nurse in the operating theater. This is a picture of him holding the scalpel with mom not too excited about the background. Okay, so another one is the clinical spectrum of acute nutritional axonal neuropathy. And the reason I put this here is we see this on the inpatient side. So this is not something you really tend to see, somebody makes an appointment and they come see us in the clinic. But patients, like for example, who get bariatric surgery, we've seen this in multiple times, or somebody who has bariatric surgery and there's something else going on like alcoholism, they can present with weakness. And the authors for this abstract sort of describe sort of the wide variety of neuropathy types in people with severe nutritional neuropathy. It can be basically a pure sensory neuropathy. It can be a pure motor neuropathy, so they present with weakness only, or a mixed bag. And interestingly, sometimes it can be like a mixed neuropathy, motor and sensory, with a myopathy. So, and we've seen some of these patients, and they can be very severely affected. Patients who get bariatric surgery are told to take vitamins, particularly if it's sort of a rerouting of the tubes. If it's a sort of a banding procedure, it's not so important, but if the actual tubing is moved around in the gut, then you can have a problem with absorption, and it's particularly important that those folks take their vitamins, or else bad things can happen. And that's basically why I thought that one was interesting. This next slide, again, there's a lot of things here on this slide, but this is basically an announcement of a clinical trial that's based mainly in Europe called the CONVEY study. And it's for a compound, it's hard for me to read it, if you guys have...
There you
There you go. You don't need your You take your vitamin A, don't you? Vixotrigine. So this is a novel agent, and this is a sodium channel blocker. So I was mentioning how the sodium channels mediate signals in our nervous system. Well, if you can block them partially, you don't want to block them completely because you'd be a blob, you couldn't move at all. But if you could block them a little bit to reduce pain signals, then that could be useful therapy. And this is a trial that's currently undergoing clinical trials, so it's something to keep track of, because it could be an effective therapy. But we don't have any results yet. The next one has to do with dorsal root ganglion stimulation. It's like, okay, what's that? So when we see patients in the neurology clinic, we try all the things that Paul talked about, but there are patients in which we try everything that we have in our disposal as neurologists, and it still doesn't work. And for those, if those patients still have pain, then we often refer them to our pain center, and they have interventional approaches that can help reduce pain. And some of those approaches include spinal cord stimulation and stimulation of the dorsal root ganglia. The dorsal root ganglia are these, I don't know if there's a pointer here. Anyway, so, hang on. Well, there's a big arrow to it, a white arrow. So the white arrow points to, there are these little tufts of cells that reside just inside of the spinal cord, and this is where the sensory neurons or sensory cells reside. And you could put a stimulator around that, and if you stimulate in such a way, you could modulate pain. And this has been studied, I think this paper looked at hereditary neuropathy, and I think idiopathic neuropathy. And the trial went well, the pain scores went way down, and 3 of the 4 subjects elected to get a permanent device implanted. And does anybody here have an implanted electrical device to modulate their pain? Okay, so is it working for you?
I had the trial, and now they're scheduled for, I'm scheduled for the permanent.
Okay, so
the trial worked.
The trial worked well, okay, great. So it's something to think about. It's a big step because it's an implanted device, so the risk of having a foreign body in, and there's sometimes issues of getting things like MRI scans, but it's easier and easier to do MRI scans now with these devices. So this is just more of what I said, and many of them didn't get it implanted. So basically, again, interventional approaches are another kind of layer of therapy that are available to you if the traditional therapies don't work. And the big advantage is these therapies are not sedating, so your brain is not affected by it. Okay, so driving ability correlated. There's a paper on driving ability correlated with the severity of neuropathy. And this is sort of a delicate topic. I have to say that I often, maybe because I don't like confrontation, I tend not to bring it up so much. I kind of let the patient bring it up. But this paper, this was done at Stanford, they basically did correlate the severity of the neuropathy with the risk of car crashes. And the risk goes up quite a lot. Let's see if I could read this here. So those with mild neuropathy had 3.9 accidents per million vehicle miles. And I know that's a figure that unless you're in the safety, highway safety realm, it doesn't mean a lot. But I think what does mean something is if you go to the moderate group, they had 11.3, and then the severe group had 12.3. So it goes up, your risk goes up by 3. And these rates are much higher than age-matched people. I think how I approach this is, if patients have a concern about it, I usually advise, and this is a very basic advice, but I advise that they take a highway safety or a driving safety more, and then and then I say, why do you care? Well, we don't want to have an accident with you on the way home, so that's why I'm bringing it up. Okay, and then and I think this is going to be the last one I'm going to talk about. Medical cannabis. Who takes cannabis? here? Probably may not want to admit it. Okay. So the staff raised their hand. All right. Okay, we're going to watch out for you on the road too. So I would say that, I mean, we're in San Francisco. It's everywhere. Matter of fact, there's sort of a faint scent of cannabis just as you walk around the streets of San Francisco. There have not been many controlled trials of cannabis for neuropathy. I do know that one major one was one that was done at UCSF at the General Hospital in San Francisco. This was done by Don Abrams and a neurologist in a former neurologist in our department named Cheryl J. And they actually did it in the inpatient setting with marijuana cigarettes, and they actually had sham marijuana cigarettes, where it's basically all the active substances were leached out. And there's a whole funny story about how they had to like vent the rooms outside so the smoke wouldn't go into the main hospital. And it did show benefit. This was in a population, the patient population was folks with HIV-associated neuropathy. Those were the patients studied. And they did say that the best responders were people that had an experience with marijuana and kind of knew it and it worked well with their body. And those people, it seems to work very well. There's some people in whom it really doesn't work. But anyway, getting to this study, the patients were fairly up there in age. I think the mean age was 81, and there was somebody aged 102. Wow. And one thing that I thought was surprising about these studies is, well, about a third reported an adverse effect or event. And this often resolved after they changed their dose. And some of the things that the folks complained about were somnolence, disequilibrium, gastrointestinal disturbance. Some had euphoria, which I think that would be a positive effect, but anyway, that was 3% of the patients. And then the symptomatic benefit was appreciated in 69% of the patient, with relief of chronic pain in 49%, sleep was improved in 18%, neuropathy 15%, I'm not quite sure what that means, maybe just, again, neuropathic pain, and anxiety was also an improvement. And then they were able to reduce their need for opioid medications. Only 7 patients, how many were there in this study? So 204 patients were in this report, and only 7 discontinued because of an adverse effect. And I'm surprised that number is so low. And many of them took a tincture that was 1-to-1 THC with CBD. So that's this one report. They say that more work has to be done in terms of randomized prospective trials, but they thought it appeared to be a well-tolerated, effective intervention. So that's out there as another treatment.
Excuse me, what's somnolence?
Somnolence is sleepiness.
Oh.
Okay, so, well, that's, I think, that, the slide now reiterates just what I told you. And I think that's the last case I was going to share with you. So again, thank you very much for having us speak. We are going to be up here together to answer questions. And I do have a couple of questions saved up from a couple of people who approached me in the transition. But again, let me thank again the organizers for having us today. On the slide, again, sort of in micro font, I have the list of the providers at UCSF that see patients with neuromuscular disorders. And as you can see, we have quite a big team. Paul is joining that team in the coming year. Also, again, it's in very tiny print, but our fax number for referrals is up on that on the slide. And again, eventually that will be posted on the website, I think, so you can, it'll be a visible font in a little bit. Okay, thanks. Let me get to a couple of questions that I think one of them what had to do with traumatic neuropathy. A gentleman came up here and said that he was, I think, in a car accident and had neuropathy. Can you say something about that? So let me say a little bit about traumatic neuropathy. Well, first of all, traumatic neuropathy would not cause a progressive neuropathy. So if we're, I don't know where that gentleman is, but if the neuropathy is still getting worse and worse and worse and worse, there's something else going on besides just the initial trauma. Trauma would cause sort of a stepwise change in the neurological status of a person, but then there's sort of a new plateau. The other thing I would say is early on after traumatic neuropathies, depending on the mechanism of injury and sort of details about the neuropathy, there's sometimes an opportunity to do a surgical intervention to restore function. So, for example, if you get stabbed with a knife and your nerve is cut into two pieces, you could put those two ends back together, and then eventually the nerves can regrow across the gap. And there are many other sort of techniques that are a little bit more fancy than that, but where you can restore function. If it's about 18 months or longer after the trauma, then you're generally kind of stuck with it to a certain extent. If there is a lot of weakness still, 18 months and beyond, orthopedic surgeons can do these things called tendon transfers, where basically one muscle is moved to work on it at a different point in the limb to provide some restoration of function. That's the motor stuff. And then neuropathic pain can be an ongoing problem, somebody with trauma. And neuropathic pain, once it starts, it can be a tricky thing to get rid of. And sometimes even when the neuropathy heals quite well, the nerve pain can continue. And I imagine that's one of the symptoms is neuropathic pain. And we address neuropathic pain and trauma basically just like the sort of the algorithm that we sort of gave before. It's sort of the approach we give. Okay, so I hope I answered your question. So I'm going to have Paul.
Okay.
I'll do the pointing.
I have small fiber neuropathy, and I was wondering if you have any recommendation for specific institutes or physicians that have more than average expertise with that?
What's the question? I couldn't hear.
Okay, yeah.
Yeah, the question is, if you have small fiber neuropathy specifically,
Yeah.
are there specific institutes that specialize in that?
Correct, yeah, that's the question.
Well, I guess I would say, so small fiber neuropathy, I would say either UCSF would be fine to see us there. Stanford is also quite good. Sometimes small fiber neuropathy can be associated with problems of the autonomic nervous system where there's difficulty with blood pressure right when you stand up or high blood pressure when you lay flat. And Stanford actually is a referral center for people who have small fiber neuropathy and so-called autonomic neuropathy. But either of those referral centers would be totally fine. I would make a plug for local neurologists. Small fiber neuropathy is something that is seen quite commonly in a neurologist's office. It may not be seen super commonly, well, maybe less common to a primary care doctor. But if your chief symptom is pain, many local neurologists could take care of that just fine.
UC Davis has a specialty in that.
That too.
Yeah. Yeah, I would agree with everything that Paul said. I think small fiber neuropathy is in sort of the wheelhouse of most neuromuscular specialists. If you're asking about sort of the big centers in the country, Johns Hopkins has done a lot of work in small fiber neuropathy. The Mayo Clinic as well, but also University of Utah. Gordon Smith there has done a lot of work in it.
Thanks.
I have a question. Can I ask about restless leg? I believe it's related to neuropathy.
No, not at all. Sorry. No. Yes, no, go ahead. Ask. Sorry, thank you. Do you want? No, please ask your question.
Is there a treatment for restless leg? I find it more difficult than neuropathy or the cancer I had. It's probably the worst condition I have, and I think it's related.
Okay, I guess it's my turn. Still, I think. So restless leg syndrome, the question has to do with restless leg syndrome and how it's managed. That's potentially a very big question. Let me just, okay, so first of all, restless leg syndrome, what is it? It's basically a symptom complex in which folks, when they're trying to go to sleep at night, they feel a buildup of sensation in their legs. It's annoying. It's often very hard to put into words what it feels like. It's very similar to neuropathic pain at night, but what's a little bit different about it is the annoying symptoms drive the patient to get up and walk around. And if the patient walks around, the symptoms should be completely eliminated. What? No. The exception to that is what's called secondary restless leg syndrome. So sometimes restless leg syndrome can be part of or a consequence of peripheral neuropathy. And those folks, they may still have some residual symptoms. And the therapies for there's special therapies for restless leg syndrome. Some of them have an overlap with the treatments for Parkinson's disease. And it can be very, very hard to treat. I'm not a restless leg expert. I'm not, but I do see patients with it because it's such a common symptom. And my approach is often to give the patients a number of treatments and have them rotate those treatments about every week or every couple of weeks. Because it seems like any one therapy develops, there's a buildup of tolerance or habituation, but it loses effectiveness if you stick with any one therapy. So my approach is to give the patient sort of a toolkit of a number of things that they try, that they rotate.
I was diagnosed with the diabetic neuropathy about 3 years ago, and lately, about a month ago, I developed a pain in my right arm from the back to the all the way to the arm. If that could be neuropathy or something else.
Repeat the question.
Yeah, so the question is, this gentleman was saying that in addition, that diabetic neuropathy, which is the one that I described, which tends to affect the feet first, causes burning in the feet. He was describing a symptom where he has a pain in his right arm that sounds like it maybe starts in your shoulder.
Yes.
The back of your shoulder. The short answer is that it's possible. The most common form of neuropathy that diabetes can cause is a neuropathy that affects the longest nerves in the body. That's why the feet tend to be affected, and it sort of tracks up over time. And really only when the diabetic polyneuropathy is so bad in the legs that it goes above the knees are the hands typically affected. With that said, diabetes can also cause a few other nerve-related conditions. Occasionally diabetes can cause an inflammatory reaction in the plexus of the lumbar or the lumbar nerves or the brachial plexus. It can also cause injury to the nerve roots themselves. So in short, I would say it's possible that could be related to diabetes. I would also say that sometimes, just as diabetes is very common, pinched nerves in the neck that sort of cause shooting pains down the arm are also common too. So I would say it would definitely be one of the possible causes, but we would need more information, like be able to examine you, that sort of thing, to be able to give you a definitive answer on that.
Thank you.
No problem. Yes, ma'am.
I recently completed chemotherapy, Taxotere. They had to lower the dose on that. My voice was quivering and chemobrain. Is chemobrain a type of neuropathy from the drugs?
Please repeat the question.
The question has to do about chemobrain. So this is a Taxotere chemotherapy, and it causes a change in voice and also sort of, patients who get these therapies do have their brain effects, and it is a neuropathy. In this case, it's a neuropathy, a central neuropathy, not a peripheral neuropathy, but you can have both. That's a very common problem. So these agents can affect the brain. Usually patients after a while, after it's stopped, feel better and their thinking returns to normal or near normal. So I'm sorry to hear about that, but it's, I would say weeks, days, it's highly variable. I mean, days to weeks to months, but usually less than a year.
Because I'm coming up on a year.
Okay.
Yes, sir.
Do any of these therapies improve balance?
That's a tough question. I would say.
Repeat question, please.
So he asked if any of these therapies that we're describing improve balance. And I think one of the biggest challenges in the treatment of neuropathy is that I would say we're pretty good at treating neuropathic pain, but unfortunately, even in 2019, we're not great at improving the numbness or the dead feeling that people feel in the nerves. And oftentimes when patients have a problem with their balance that's related to a neuropathy, it's because they don't feel the ground quite very well, and they have trouble knowing where their feet are in space, and that causes them to be off balance. The one exception is occasionally patients who have a neuropathy from B12 deficiency, vitamin B12 deficiency. That can cause a separate form of imbalance that's related to the organ of balance in the brain called the cerebellum. And when you replete their vitamin B12 and they feel imbalanced, oftentimes that balance will improve. But when balance is associated with numbness from neuropathy, that's more difficult to treat, and we unfortunately don't have a great pill for that or infusion for that. We really just have to try to treat the underlying condition and hope that the nerves start to regenerate and repair on their own. Yes,
One question
Tom
here.
is here.
Oh, sure.
So first question is next to Dr. Ralph. And the question relates to the opioid kappa pathway and whether modulating that would be useful for neuropathic pain. And the reason for my question is because there's a company called Nectar down in the Peninsula, which has a senior registration trial underway for peripheral pain related to the kappa receptor.
I don't know if I have an answer for you, actually. So I think the answer for that is I don't know. So the question had to do with this new opioid sort of avenue of therapy. I don't know, Paul, if you have anything to say.
No, we actually discussed this between talks, and I don't know any more than Dr. Ralph does, unfortunately. I would need to read more about it.
Yeah. Maybe you could, I'll make a note and then maybe get back to you, but I don't have a good answer. But let me just, there are a couple of things I want to address. One is, I'd just like to add a little bit to what Paul said. I mean, there are certain neuropathies in which balance can improve rarely. So for example, a patient with CIDP that has poor balance, if those patients are treated, their balance can improve markedly. And then also, again, there was another question that I received that I'd like to address before I forget. I think it was Marilyn asked about progression of neuropathy, because we didn't really address that. And I think the reason we didn't address that is it's very highly variable. But we can say something about idiopathic neuropathies. So even though we don't know the cause, let me just say a few words about idiopathic neuropathies. So patients who come in with an idiopathic neuropathy, first of all, they tend to be sort of middle-aged or older. And number two, they come in because of sensory symptoms, by and large, numbness or tingling. They may come in with balance as well. And so if you have an idiopathic neuropathy, those usually progress very, very slowly, such that if you see the doctor at yearly visits, there usually isn't much evidence of progression, but maybe at 5-year visits, the symptoms have moved up, maybe like a number of inches up the leg, and there's some new symptoms and new findings. But it's usually very, very slow for the idiopathic neuropathies. But there's if you take the whole subject of neuropathy, there's an extremely wide range of rates of progression, from Guillain-Barré syndrome, where things change every minute almost, to some neuropathies that change not at all.
Hi. Okay. Right.
Was there?
No, I asked that question.
Oh, okay, yep.
I just wanted to add to that. So I would like to know, I have idiopathic neuropathy, and I would like to, my symptoms, they sort of go up and down. If it exacerbates, then I rested like a sore muscle. You know, and then I feel better. You know, I don't know why I sort of figured that out over the years. But I would like to know, like, how am I progressing with it? If I had a periodic EMG test, would that answer my question?
Well, it's still is.
Yeah, sure. Yeah.
Okay.
So the question was about progression,
Yes.
fluctuations, and also monitoring, I think.
Correct.
So it is something I think we commonly hear about. Patients feel that their neuropathy symptoms fluctuate, and often that has to do with the activity they did that day. And the way I think about it is when you have a neuropathy, your nerves have less reserve. And so when you do something that is very strenuous or you walk a long time, there's less reserve for those nerves that are still working to compensate. And oftentimes afterwards, they do feel like a sore muscle because they've been overworked in a sense. The question about progression is a really good one, and I would say, and one of the reasons you'll see us in the clinic taking very, very detailed notes is we follow patients' exams very closely, and we recapitulate that exam very closely in a way to give an objective assessment. If between visits, say 6 months or a year, we see a change in function. I think it's hard as a patient to know if things are progressing because you live with your symptoms every day, and it's hard to know if things are on the going down or improving. So part of it is that clinical exam, and also part of it is what you're pointing out, which is the EMG test. That test can provide us with some objective numbers that we can follow to see if the neuropathy is getting worse or getting better over time. And that's really dictated by who your neurologist is. Some people will get there's concern that things are rapidly progressing. We're repeating EMG maybe every 3 months. For things that are very, very slow, we may repeat an EMG every couple of years. It sort of depends, but that is a good way that we follow neuropathy. You have the mic.
Hi, can you hear me? Can you hear me? No. Can you hear me now?
Yep.
I have a question about brain plasticity. Would it affect the syndrome at all?
The question has to do with brain plasticity.
Yeah, brain plasticity. Could you do certain exercise to help the neuropathy and help it that way?
It is connected. So the question has to do about brain plasticity, which generally that's about is the adaptability of the brain and of the brain, and the brain is quite adaptable. I think this is connected mainly with patients with balance problems, and patients with neuropathy that have balance problems, they can benefit from things like physical therapy that focus on balance, and patients can also do activities such as Tai Chi that help. So, I mean, basically those exercises are a way to utilize the brain plasticity, where the brain sort of learns to live with receiving sensory input from other parts of the body to maintain balance. So that's sort of an answer. I'd just like to add to, because I think it was an important question about asking about progression. I think, patients often, one of their big concerns is whether or not they're going to be disabled by their neuropathy. And that sometimes it's not said explicitly, but that's often sort of a major fear. For patients with idiopathic neuropathy, by and large, those patients are able to walk their whole lifetime. So it's rarer for a patient with an idiopathic neuropathy to ever be wheelchair bound because of the neuropathy. Balance can be a problem. So patients, if they've had it for a number of years or decades, they may need a walking stick to help with balance. But patients usually do overall quite well and from the standpoint of being able to walk, even if they've had it for many years.
A follow-up question regarding neuropathy and lumbar nerves with regard to spinal stenosis and degenerative disc, DDD. Is there a relationship there?
Well, I think, so the question was, so the question was about spinal stenosis and degenerative disc disease, and is there a relationship with peripheral neuropathy? The short answer is that in the lumbar spine, you have a few lumbar nerve roots which go down and supply and end up being the nerves in your legs. If there's a problem at anywhere along the nerve pathway, whether it's at the nerve root level in the spine or further down in the feet, you're going to have symptoms of essentially neuropathy, where you'll get burning sensations in the areas that those nerves supply. So sometimes it can actually be a little bit confusing because, for example, the fifth lumbar nerve and the first sacral nerve are responsible for the majority of sensation and motor function below the knee. So that if somebody were to unfortunately have a pinched nerves from degenerative disc disease at multiple sites, say both fifth lumbar nerves and both first sacral nerves, that can mimic a polyneuropathy. And actually that's part of the reason we do the EMG test, is because the EMG test helps us localize where the problem is. If it's more of a peripheral neuropathy affecting the distal nerve branches, or if it's more of a nerve root problem up in the spine that's higher up at the nerve roots. So they're related in that sense that they can mimic one another, but not related in the sense that oftentimes the same thing is causing one or the other, rarely both. Yes, sir.
Yeah, would you speak to the treatment modality of a spinal cord stimulator?
Okay, that's another tough one. I don't know if I could fully explain that. I'm not even sure that the designers of it can fully explain how it works. It probably involves, so in the nervous system, in many pathways in the nervous system, there are excitatory circuits and inhibitory circuits, as you may remember from your anatomy background yourself. And so pain signals also have that kind of circuitry, and there's a phenomenon called gating, where signals can, if they go into particularly the back part of the spinal cord, they can sort of block the pain signal from going up into the brain. And I think that the spinal cord stimulator sort of helps with basically improve that gating, or in other words, blocking the pain signal from going up top, basically.
You want to explain how it's done? The device?
I don't know if I could, well, so that's, as I mentioned, we, as neurologists, we do a lot of, we're cognitive doctors, we're supposed to do a lot of thinking, but we don't do anything. I'm joking, but we're cognitive specialists. We do EMGs and we do things, but those are implanted by anesthesiologists and other practitioners. And it's a whole science about that. And I think if your question has to do with pulse width, voltages, and that kind of thing, I'm not sure I can really answer that. I mean, there are people that can, but that's sort of outside my specialization. But like I said, my approach is if a patient reaches the end of the things that we're familiar with in terms of, the medications, topical therapies, and all the things that we talked about earlier, then I refer them to doctors that have deep knowledge about that.
Follow-up question.
Yeah.
Can you say anything about the placement of the electrodes for that procedure?
Well, so the placement can be at the nerve, generally at the nerve root level, or those little tufts of nerves that we're talking about called the dorsal root ganglion.
If you're going to use a TENS machine, for example, would you put them on both sides of the spinal cord? Or?
Okay, so the question has to do with a TENS unit. So that's a transcutaneous stimulator, and generally speaking, people apply those to the painful part of the body. So if you have pain in your feet, you would put the pads on your feet. There are some fancy electrical stimulators that also, again, it involves sort of this gating theory of pain. There's this thing called the scrambler unit, for example, which has multiple pads, and it has sort of a complex program. And those pads are placed in a number of locations in the limb. But in general, the pads, particularly with a single channel stimulator, or basically 2 pads, that's placed in the painful area. Now it's conceivable, because patients, you have to sort of try different approaches. It's conceivable that a patient could get some benefit with pads on the surface, but the stimulator is such that the current path will be very superficial, so really go through the skin and it will go through the superficial muscles and not really get into the spinal pathways with a skin technique.
So these new machines that actually put the electrodes into the body.
That's right, they're deep in the spinal canal. So I guess so I can answer that question well. There's also some fancy stuff that involves even implanted devices that stimulate the nerves peripherally. And we have a colleague named Dr. Jacques, who's a neurosurgeon. She implants some of these devices. So it's a cutaneous stimulator that's implanted. So that's another therapeutic avenue. But I do kind of defer discussions about exactly the nuts and bolts to her, because she's the one that actually has to put in the wires.
I have idiopathic neuropathy, but I also have numbness on my lumbar area. Is that related?
Another easy.
Well, I don't think it would be, but you may disagree with that. Huh?
Yeah, I mean.
You said lumbar, like numbness in your lower back?
Mostly buttocks.
I think the difficulty with idiopathic neuropathies is idiopathic means that we don't know what's causing it. So I feel like I would be remiss in saying, oh, definitely not, because if you don't know what's causing it, I think it's kind of an open question. It's possible. I guess what I would say is the idiopathic neuropathies that we tend to see tend to be these slowly progressive neuropathies that affect the distal muscles in the feet. And they very slowly over time will kind of track up to the ankles, rarely involve the hands when they're truly idiopathic. Now, is it possible that your idiopathic neuropathy is related to some gene that we haven't identified that also preferentially affects the nerves that control the sensation to your lower back? I suppose that's possible, but when it's idiopathic, it's hard to know.
Can I benefit from genetic testing?
Yeah, some of these, I mean, to answer your question really would require an evaluation. It's hard to answer. There are, as discussed before, there are multifocal neuropathies in which patients can present with numbness in multiple body regions. Matter of fact, one of the neurologists at UCSF had such a condition with numb patches all over his body, and he wrote about it. This is in the 1950s. But it could be that you have a combination of things. You could have a distal polyneuropathy with lumbar spine disease. So the nerve roots that come off the lumbar spine, there's a little branch that goes to the back, particularly in the midline back, and that can be damaged. So there are a number of possibilities that would require examining you and potentially testing to really sort it out.
One last bit. So the mechanism of the immune polyneuropathies, where I think there is some degree of demyelination. And this obviously raises similarities to multiple sclerosis, where there is much more severe demyelination. So the question, therefore, is whether the MS drugs would have any potential utility for treating the immune polyneuropathies as opposed to the steroid course.
It's a great question. So some of the drugs actually, there is overlap. And it's probably not the ones you're referring to, but for example, when people have MS attacks or these immune attacks on the nerves, we do treat them with similar things. For example, people who have bad MS, we'll treat them for plasmapheresis or we'll treat them with IV steroids. The question about the specific MS drugs, these are the drugs that sometimes people take subcutaneously, take by mouth, rarely get specific infusions every 6 months or so. We don't tend to use those medicines because they haven't been approved for that. So is it possible, for example, that some of these medications like Copaxone, for example, could potentially be beneficial? I would say it's possible, but it's just never been proven, and so we don't use it. There are actually a few of these antibodies that we've identified that have been shown that they can, although they mostly cause an attack on the nerves, they can also cause some of these demyelinating lesions in the brain that are similar to MS. So there's probably a similar mechanism there, and we're sort of learning more and more about that overlap. But these other medicines that you may have heard of that people are on, Copaxone, Tecfidera, Gilenya, these medicines we don't currently prescribe for these immune neuropathies. And quite frankly, actually, the immune neuropathies, we do feel pretty good about how we treat them. The one example, the one actually overlap that I didn't mention is a drug called rituximab, also known as Rituxan. That is one infusion that, as Dr. Ralph is standing here over my shoulder, I remembered to point out is rituximab is a medicine that you can use for both. That is effective, and that is an infusion.
I wanted to make one comment ahead of time. I will be down. Is this working?
I'm not sure it's amplified. We can hear you, though.
All right. I want to make one positive statement about alpha-lipoic acid. You seem to be a little hesitant, and you don't have probably the testing I've done personally. And I've talked to Dr. Ralph about it because we do have people that take it, it doesn't seem to do anything. And sometimes they stop taking it and they find out it did do some things. But my neuropathy is hereditary of sensory autonomic. And I find that we were having some real problems with my autonomic system, and I started alpha-lipoic acid, and that seemed to help a lot. And it has made a difference. And I accidentally I put my pills in a three weeks schedule, and I put them in a little container for 3 weeks. And one time, about 3 months after, but in the year that I found out that it was really helping me, I accidentally didn't take the morning pill for 2 weeks, and I started noticing symptoms coming back. And I reiterated, I put them back again, and the symptoms went away. And I've even found once in a while I'll forget a few days on the night pills, and I'll notice a little bit of difference. So I know that for me, alpha-lipoic acid is a lifesaver. And I talked to Dr. Ralph because I thought maybe it has more interest, maybe more impact for the autonomic system than it does some of the other systems. And that's why maybe some people can take it and other people can't. Don't find that much help. And that might be a study that could be done to find out all that kind of thing. But I know that I also tell people if they're having any stomach concerns, and they have to, but I also tell them talk to the doctor first, because they need to know when the doctor says, hey, I stomach can't handle this, or something of that sort. But I take the S form, I take the regular form, I don't take the R. So that, and I have people that they decided that the financial reasons they took the S, and it was for them. And I wanted to introduce Daryl Sullivan, and he has an announcement.
First off, we want to thank these gentlemen for their very excellent